And I see it. All right, so welcome to everyone. Good afternoon. And on behalf of the Family Medicine Graduate Program and Dr. Maria Matthews, I'm pleased to welcome you to Dr. Nisanthini Ravichandiran's lecture for her Family Medicine Masters of Clinical Science. Dr. Matthews and I have had the pleasure of working with Nisha on her master's work. Our format today is that Nisha will give what is unfortunately not a public talk, but will give her talk to us for about 25 minutes, after which we will take a short little break before we resume the exam. And at that point, when the exam begins, we'll hand the reins over to Dr. Shannon Sippold, who is our exam chair today. So it is my pleasure to introduce Dr. Ravichandran. Nisha completed her undergraduate studies at the University of Toronto in human biology. She then did her medical school at Western, and then she left us to pursue her family medicine residency training at McMaster University. And we were really pleased when Nisha decided to return to Western to do her graduate education. Nisha is a member of the College of Family Physicians of Canada and is a practicing family physician in a family health team in Scarborough. She's also a lecturer at the University of Toronto. When Nisha and I first talked about her thesis topic, she was thinking about doing something along the lines of technology and patient self-management apps. But as her practice grew, she approached me about switching gears. Nisha was, and is, practicing in a multicultural area with a very high immigrant population, and she was starting to see some of the challenges that her patients were facing. This led Nisha to her interest in immigrant health and also led her to her master's thesis work. I'm speaking for both Maria and myself when I say it has been an absolute pleasure watching Nisha grow intellectually through the course of her master's degree. And so now it's time to turn those reins over to Nisha.
Thank you, Dr. Ryan. And thank you everybody for being here. So today I will be talking about my thesis, Utilization of Health Care by Immigrants to Canada, a cross-sectional analysis of the Canadian Community Health Survey. And of course I was supervised by Dr. Bridget Ryan and Dr. Maria Matthews. So I'll be starting with a little bit of an introduction and a quick review of the literature. So we know that there are numerous barriers faced by immigrants to utilizing healthcare in Canada. We also know that this lower utilization of healthcare by immigrants is associated with deteriorating health of individual immigrants over time, as well as ultimately costs to the healthcare system. And the hope is that by studying utilization, this can help to inform policymaking to help improve utilization of healthcare by immigrants in Canada. Unfortunately, though, there are several gaps in the literature, and this thesis attempts to address some of those gaps. So there are several different outcome measures that have been previously used to look at utilization of healthcare. And in this thesis, we focus on two specific outcome measures, having a regular healthcare provider and the number of medical consultations. In terms of the existing literature on having a regular healthcare provider, this was actually one of the most frequently used outcome measures in the literature. And we know that having a regular doctor leads to less difficulty in accessing routine care. However, most of the literature actually focused on either comparisons between Canada and the United States or comparisons between immigrants and non-immigrants in Canada. There were fewer studies that looked at specific characteristics of immigrants that might increase or decrease their ability to have or to find a regular healthcare provider. We do know from the existing literature that immigrants who are white, female, married or common law, or higher income were more likely to have a regular healthcare provider or to have a regular doctor. The second outcome that we looked at in this study was the number of medical consultations. And this is a significant gap in the literature. We were only able to find one study that looked at the number of medical consultations in the past year as an outcome measure, and this was a small practice-based study. In this study, the primary exposure variable of interest was time since immigration. In the existing literature, we were able to find 4 Canadian studies that looked at time since immigration as an independent variable. And from this literature, we know that established immigrants are more likely to have a regular doctor compared to recent immigrants. However, there are several limitations for the existing literature. Several of the studies had a relatively small sample size, and the studies used older data from prior to 2012. In fact, the most recent study that was based on data in 2012 excluded immigrants over the age of 65, which are, of course, an important segment of the immigrant population. So the objectives of this study were firstly to examine the relationship between having a regular healthcare provider and time since immigration. And the hypothesis was that a smaller proportion of recent immigrants would have a regular healthcare provider compared to established immigrants. And the second objective was to examine the relationship between the number of medical consultations in the past year and time since immigration. And the hypothesis was that recent immigrants would have fewer medical consultations in the past year than established immigrants. So to get into a little bit of detail about the methods, the design of this study was a secondary cross-sectional data analysis using the 2015 to 2016 public data set of the Canadian Community Health Survey, which is the most recently available data set. We looked at two different dependent variables. The first was having a regular healthcare provider, which is a dichotomous variable. And the second was the number of medical consultations, which was a count variable. The study was guided by the Anderson and Newman framework for utilization of healthcare. The Anderson and Newman framework suggests that utilization of healthcare depends on the interaction between societal determinants, features of the health service system, and individual determinants. And specifically, individual determinants include predisposing factors, which describe an individual's propensity to utilize healthcare. And these might include demographic variables such as sex, age, and race, as well as belief or cultural variables such as beliefs about health and illness and beliefs about healthcare. Secondly, enabling factors are those factors that determine an individual's ability to access healthcare services. And these might include things like income, language proficiency, or insurance for prescription medications. The third type of individual determinant are need factors or illness level, which are determined by an individual's perceived or evaluated illness. And this might include, for example, the number of medical conditions or self-perceived health. So the selection of independent variables in our study was guided by the Anderson and Newman framework, which I showed on the previous slide. And the primary exposure variable of interest was the time since immigration. We also looked at predisposing, enabling, and need factors. So predisposing factors that were included in the analysis were sex, age, region, marital status, race, and sense of belonging to the local community. Enabling factors that were included in the analysis included income, education, knowledge of the official languages, English and French, and insurance. And specifically for the analysis of the number of medical consultations, we also included the first outcome measure, which was having a regular healthcare provider, as an independent variable. And finally, for need factors, we looked at perceived health and number of medical conditions. So the participants that were, or the respondents that were included in this study were respondents to the Canadian Community Health Survey 2015-2016, who were immigrants and who were age 18 and above. Specifically to address the two objectives, we looked at two samples. So for objective one, which was to determine the relationship between having a regular healthcare provider and time since immigration, we included only those respondents who answered those questions about having a regular healthcare provider and time since immigration. And this left us with sample one. For objective two, which was to determine the relationship between number of medical consultations and time since immigration, we included only those respondents who answered those questions about number of medical consultations and time since immigration, which left us with sample two. For both sample one and sample two, which reflected objectives one and objective two, we conducted a descriptive analysis followed by a bivariate analysis to determine the effect of each independent variable on the dependent variable. And then we conducted a multivariate analysis, which included testing for interactions. So for the outcome variable having a regular healthcare provider, we conducted a logistic regression. And for the outcome variable number of medical consultations, we conducted a negative binomial regression. And I just want to make a comment here about this outcome measure, number of medical consultations. You might notice that in my thesis, I actually presented the results of a Poisson regression. However, when I was preparing for the defense and looking at the assumptions of the Poisson regression, I realized that one of the assumptions was that the mean and the variance are approximately equivalent, which was not actually the case for our sample. So the negative binomial regression was the more appropriate analysis. So in this presentation, I am presenting the results of the negative binomial regression. And with the final draft of the thesis, I will make that change. I will just highlight here, though, that changing the regression model that was used didn't significantly affect the results or the conclusions that we were able to draw from those results. And finally, for both Objective 1 and Objective 2, we conducted a supplementary analysis. And this was because we had a relatively high missing rate for the exposure variable of interest time since immigration. So we wanted to make sure that sample 1 and sample 2 were not biased. So in order to ensure this, what we did was that we included all respondents, regardless of whether they had answered the question about time since immigration. And we conducted all of the steps, the descriptive, bivariate, and multivariate analysis, without including time since immigration as an independent variable. And this helped us to determine whether sample 1 and sample 2 were representative. And I'll be presenting those results quickly later as well. So to move on with the results, I'll start with the results for our first objective, which was having a regular healthcare provider from sample 1. And starting with the descriptive statistics, we found that 84% of respondents did have a regular healthcare provider, and 76% of immigrants who responded were established immigrants, which we define as immigrants who were in Canada for 10 or more years. 24% were recent immigrants who had been in Canada for less than 10 years. 78% of respondents were under the age of 65, and 65% of respondents were white. 70% of respondents had at least a post-secondary school education, and 96% of respondents were proficient in at least one of the official languages. 56% of respondents had either very good or excellent self-reported health, and 27% of respondents had 3 or more medical conditions. So because the primary exposure variable was time since immigration, we conducted a stratified descriptive analysis to compare the outcome measure as well as the predisposing, enabling, and need factors between established and recent immigrants. And from this analysis, we found that a higher proportion of established immigrants had a regular healthcare provider compared to recent immigrants, and that a higher proportion were age 65 and above, and a higher proportion were white compared to recent immigrants. When we looked at enabling factors, we found that a higher proportion of established immigrants had a higher income, but a lower proportion had a post-secondary education compared to recent immigrants. And finally, in terms of need factors, we found that a higher proportion of established immigrants had poor or fair health, and a higher proportion had 3 or more medical conditions compared to recent immigrants. So finally, for the outcome measure having a regular healthcare provider, we conducted a multivariate logistic regression. And shown in blue are the variables that were found to be significant in the multivariate logistic regression. These were time since immigration, sex, age, marital status, sense of belonging to the local community, household income, education, self-perceived health, and number of medical conditions. In the next slides, I'll present the details of the variables that were found to be significant, but I do want to mention that none of the interactions that we tested were found to be significant for this outcome measure. So for the primary exposure variable, which was time since immigration, we found that established immigrants were 1.8 times more likely to have a regular doctor than recent immigrants. In terms of the predisposing factors, in yellow, you'll see that females were more likely to have a regular doctor than males. In red, you'll see that with increasing age, respondents were more likely to have a regular doctor. In green, respondents who were married or common law were more likely to have a regular doctor than respondents who were single. And in purple, you'll see that respondents who had a somewhat strong or very strong sense of belonging to the local community were more likely to have a regular doctor. In terms of the enabling factors, in blue, you'll see that with increasing income, immigrants had were more likely to have a regular doctor. And in yellow, you'll see that immigrants with a post-secondary education were actually less likely to have a regular doctor compared to those with less than a secondary school education. In terms of the need factors, in green, you'll see that with better self-perceived health, immigrants were less likely to have a regular doctor. And in red, you'll see that with higher number of medical conditions, immigrants were more likely to have a regular doctor. So as I mentioned in the methods, we did conduct a supplementary analysis for both samples. So for sample 1, we looked at the entire sample regardless of whether they answered the question about time since immigration. And we found that based on the bivariate as well as the multivariate analysis, there was no significance in either the magnitude or the direction of the relationships between the supplementary analysis and the main analysis. Next, I'll be presenting the results of the second outcome measure, number of medical consultations. So in terms of the descriptive statistics, we found that the mean number of consultations in the past year was 3.37 with a standard deviation of 4.53. The descriptive statistics were, in terms of the predisposing, enabling, and need factors, were very similar for sample 2 and sample 1. So I won't be showing these in my slides, although they are reported separately in the thesis. Again, we compared recent and established immigrants, and we did see that established immigrants had fewer medical consultations in the past year than recent immigrants. However, you'll see on the next slide that after we actually controlled for all of the other independent variables, there was no significant relationship between time since immigration and the number of medical consultations. So what this slide is showing is the results of the negative binomial regression. And in blue, you'll see the independent variables that were found to be significant for a number of medical consultations. And these were sex, age, region, having a regular healthcare provider, self-perceived health, and number of medical conditions. In red are shown the variables that were not significant. And at the bottom, you'll see that the interaction that was found to be significant was the interaction between age and sex. So again, just to highlight, the primary exposure variable, which was time since immigration, did not have a significant effect on the number of medical consultations. And in terms of the predisposing factors, because there was a significant interaction between sex and age, we reported separately each combination of sex and age. And we found that females who were age 18 to 39 had more medical consultations than males age 18 to 39, which was the comparison group. Other than that, there was actually no significant differences between the other age and sex combinations in terms of the outcome measure number of medical consultations. We did find that there was a small but statistically significant effect of region, where immigrants who were in central Canada had slightly fewer medical consultations than those in Western Canada. In terms of enabling factors, we found that immigrants who had a regular healthcare provider had more medical consultations than immigrants without a healthcare provider. And in terms of need factors, we found that immigrants with better self-perceived health had fewer medical consultations, and immigrants with more medical conditions had more medical consultations as well. And again, just as in sample 1, because of the high missing rate of the primary exposure variable time since immigration, we again conducted a supplementary analysis. And similar to sample 1, we found that there was no significant difference in the magnitude or the direction of the relationships between the supplementary sample and the main sample. So I'll move on to a little bit of discussion and interpretation of these results. So for our two objectives, the first was to determine the relationship between having a regular healthcare provider and time since immigration. And we found that established immigrants were 1.75 times more likely to have a regular healthcare provider than recent immigrants. And this was similar to findings in previous studies, although I will note that the gap seems to be narrowing. So compared to previous studies, the difference in having a regular healthcare provider between established and recent immigrants seems to be narrower. Now, the second objective was to look at the relationship between the number of medical consultations and time since immigration. And here we found that there was no significant effect of time since immigration on the number of medical consultations. As I mentioned before, there are very few studies in terms of this particular outcome measure, and the study that does exist is a small practice-based studies. So it is difficult to make comparisons to this one, which is a larger secondary data analysis. So we do know that there are differences between recent and established immigrants in their utilization of healthcare. And of course, one of the reasons for those differences is just by virtue of the fact that established immigrants have been here for longer, they are older, which explains some of the differences. But we do believe that there are other more complex processes that are also involved in these different patterns of utilization between recent and established immigrants. So two processes that might be involved are firstly, the shifting of immigration policy in Canada over time, and secondly, the economic and social integration of immigrants. So in terms of immigration policy, over time in Canada, there has been more preference for economic class immigrants compared to family and refugee class immigrants. And economic class immigrants are accepted to Canada based on a point system, which was established in the 1960s. But the point system has changed over time based on basically political priorities in terms of immigration. So since the 1990s, there has been increased preference and priority given for human capital, which can include things like preference for younger and more educated immigrants. At the same time, the Canadian Multiculturalism Act, which was introduced in the 1980s, has led to increased diversity of immigrants being accepted to Canada. And in fact, in our study, we did find that about 80% of recent immigrants were non-white compared to only 60% of established immigrants. In keeping with the changing demographics that we would expect based on this shifting immigration policy, in our study, we did also find that recent immigrants were younger as well as more educated compared to established immigrants. And of course, with the changing profile of immigrants that are entering the country, we would expect that there would be changes in their patterns of utilizing healthcare. The second process that might be involved in terms of the differences between recent and established immigrants is the economic and social integration of immigrants in Canada over time. So in terms of economic integration specifically, we know that immigrants face certain barriers in the labor market compared to non-immigrants. And we know that some of these barriers are exacerbated for recent immigrants. For example, immigrants might have fewer Canadian contacts, they might have fewer Canadian credentials, they might have lower language proficiency, and they might have less of an understanding of Canadian workplace norms. And the expectation would be that over time since immigration, established immigrants would have fewer of these barriers and would therefore have fewer disadvantages in the labor market and higher income. And in our study, we did see that established immigrants had higher income than recent immigrants. With higher income, there would be more social resources, fewer unmet health needs, fewer financial barriers, and more access to insurance for example, prescription medications and other healthcare services, which could lead to increased utilization. So that's economic integration over time. The other process is social integration over time. So we know that immigrants, based on the qualitative literature, do face barriers to utilization of healthcare that can fit into the umbrella of predisposing, enabling, and need factors. So for example, immigrants might have less knowledge of the healthcare system, and this might be exacerbated for recent immigrants compared to established immigrants. Recent immigrants might also have treatment preferences that are more aligned with their country of origin, which might lead to negative perceptions of services. In terms of enabling factors, recent immigrants might have more cultural and communication barriers than established immigrants, and recent immigrants might also have more need for support. So working along with this process is the social integration of immigrants over time. So as I mentioned, multiculturalism policy at least attempts or aims to promote cultural freedom and cultural diversity. And in addition, social programs such as language programs and job training and language acquisition by immigrants over time helps to facilitate social integration, which leads to an increased sense of belonging to the community by immigrants. In addition, from the healthcare system perspective, receiving culturally appropriate care and having access to same language providers might help immigrants to feel more socially integrated. And this entire process of social integration might help to mitigate the effects of the barriers that are mentioned above that might be faced by recent immigrants. So to quickly discuss the strengths and limitations of this study, one of the strengths of this study is that we focused on an immigrant population. So as I mentioned, much of the quantitative literature looked at either comparisons between Canada and the United States or between immigrants and non-immigrants. But by focusing in this study on an immigrant population, we were able to really delve into the characteristics of immigrants that might affect their ability to utilize healthcare. In this study, we also looked at two important outcome measures, which represent two points of entry into the healthcare system. The first is finding a regular doctor, and the second is actually having a consultation with the regular doctor or with the doctor in general. And the third strength in this study is that we looked at important independent variables. So our primary exposure variable was time since immigration, which allowed us to compare recent and established immigrants. And we also looked at two unique variables that have not been included in the previous literature. One is the sense of belonging to the local community, which is of course such an integral aspect of the immigrant experience. And the second is that for the second outcome measure, number of medical consultations, we included having a regular healthcare provider. And this helped us to avoid confounding the results. And finally, we conducted a supplementary analysis to ensure that there was no bias in the samples. We did have some limitations. So by the nature of the study as a secondary data analysis, our choice of variables is limited to what was available in the original data set. So for example, the Canadian Community Health Survey has, of course, lots of important variables, but some of the modules are optional and the provinces don't always opt into the optional modules. So for example, one variable that we were very interested in was unmet health needs, but unfortunately there was a very low response rate for that variable. In our case, we were limited to race as white and non-white, and of course it would have been interesting to compare other racial groups in terms of immigrants. And although this variable is collected in the original data set, the information is suppressed in the public data set to protect confidentiality. And finally, we were interested in looking at the effect of rural-urban status or size of the community, but unfortunately this was not a variable that was included in this particular data set. Similarly, our primary exposure variable, time since immigration, is only reported as a dichotomous variable of less than 10 years or more than 10 years since immigration. And of course, it would be interesting to look at the effect of different periods. So is there a difference between immigrants who've been in here less than 5 years or 5 to 10 years or more than 10 years? And unfortunately, that information was not available in the data set. Another important limitation is the definition of immigrants. So immigrants were identified in the survey by a question that asked, have you ever been or are you a landed immigrant to Canada? And of course, different respondents' understanding of this terminology might differ. And this unfortunately doesn't give us information about refugees. So there was no variable that identified whether the respondent had ever been a refugee. And of course, refugees might represent a particularly vulnerable segment of the immigrant population, which unfortunately we couldn't study in this particular analysis. And finally, there is some inconsistent terminology between different iterations of the CCHS. So for example, previous iterations used the terminology of regular doctor, while the more recent one that we used in this analysis used the terminology of having a regular healthcare provider, which makes it more difficult to make comparisons across different data sets. In terms of future directions, there's definitely lots of important questions that we'd love to continue exploring. It would be interesting to look at the effect of time since immigration on the type of care received by immigrants, and particularly to look at care that might be influenced by the age of immigrants. For example, child health and maternal care, and care that might be influenced by cultural beliefs, for example, mental health, preventative care such as pap smears, for example, and continuity of primary care. In addition, it would be interesting to look at the effect of time since immigration on the location of care. For example, whether immigrants are receiving care at regular doctor's offices or at a walk-in clinic or in the emergency department. And unfortunately, we weren't able to do that in this study, but it would be very interesting to look at this as a potential outcome measure. And finally, there's lots of room here for qualitative research, specifically qualitative research to compare the experiences of recent and established immigrants. So I just want to finish with acknowledgements and gratitude towards my supervisors, Dr. Bridget Ryan and Dr. Maria Matthews, who have guided me throughout this whole process. And of course, to the Faculty of Graduate Studies in the Center for Studies in Family Medicine at Western University for giving me this opportunity, especially Dr. Judy Brown, and to Liz McInnes for all of your administrative support. And I just want to also say thank you to my mentors and my family for all of their support.